Okay, so sorry to cut it off briefly, but I think it's better to break it up like this. So back to myasthenia gravis, and so we've always kind of taught myasthenia gravis with these cholinergic drugs because they can be used to treat it, and it's a good kind of teaching tool to look at agonism and antagonism at these receptor sites. And so I'm sure pathophys and some of these other disciplines will talk about what myasthenia gravis is. Um, and basically, it's a kind of a progressive muscle weakness that's really kind of driven by an autoimmune disease specific to the uh, acetylcholine receptors. And so, these patients can have droopy eyelids, they can have vision problems, they can be unstable in terms of their walking, speech and breathing and swallowing and stuff might be compromised because of all of this, all of these muscle problems. Some patients in hot weather exhibit or complain about muscle soreness. And the drugs that we use to treat it include acetylcholinesterase inhibitors. And so specifically pyridostigmine and neostigmine have kind of been used historically to treat myasthenia gravis. And they kind of have this ability to treat this disease quite well because of their kinetics. And so, they are reversible, but they persist at least in a long enough time where the patients can take daily or even twice daily administrations of these drugs and kind of control their disease. We will revisit acetylcholinesterase inhibitors in the context of the neuromuscular junction for surgery in a much later block, probably next year. So we will come back to the neuromuscular junction at some point. The other thing that we always talk about is what's called the tensilon test, and tensilon is the brand name for edrophonium. It should be called the edrophonium test, but clinically it's called the tensilon test. And we can use a really short-acting acetylcholinesterase inhibitor to actually gauge how well we are medicating these myasthenia gravis patients. And so if they have more weakness, basically with the test, it translates to them being over medicated. If they experience less weakness with the test, basically translates to them being under medicated, and we'll show you what that looks like. Oh, sorry. And so here's that neuromuscular junction. And so you can see those autoantibodies kind of destroying normal physiology. They bind to those receptors, of course, and then if the antibody is bound to the receptor, acetylcholine cannot. And so that's kind of where a lot of these muscular problems come from. And of course, the most commonly used muscles are affected first, and so you can see, eye changes, at least in this patient that's shown here. And this basically shows the same thing. This influx of sodium that happens when acetylcholine is bound to these receptors facilitates muscle contraction. There's, reduced muscle contraction here because, all these antibodies are binding to these receptors. And of course, no matter how much acetylcholine is in this synapse, if these autoantibodies are bound quite heavily to these receptors, the activity doesn't occur. And so we talked about a little briefly about tensilon or edrophonium. And so, how do we use this medication to basically determine if our myasthenia gravis patients are being properly medicated? And so here's your myasthenia gravis patient. All of them have low amounts of acetylcholine because or low amounts of muscle activity because they have proper amounts of acetylcholine. They just don't have the receptors that are free to do the muscle contractions. And so what you can do is you can have a patient and you supply tensilon or edrophonium and you look at how the patient does after that drug is administered. If the patient experiences less paralysis, basically means that there's a little bit more acetylcholine postsynaptically, you know that you need to increase the medication. If the patient experiences more paralysis, you can surmise that they're probably overdosed, and this more paralysis is going to be evident by lots and lots of acetylcholine. we know to decrease the medication. And of course, this adrefonium or this tensilon test in these patients will also experience bradycardia because now you've got all this acetylcholine hitting these muscarinic M2 receptors. And of course, if the patient's bradycardia, we can treat with atropine. Okay, and so that's another kind of telltale sign that perhaps you've got an overdose patient when their heart rate falls precipitously with adrefonium. Okay. And so we can also look at it at the receptor level. If you see less paralysis, you can basically feel comfortable that there's not enough acetylcholine to reach the action potential. And if you see a lot of paralysis, you can basically say that there's too much acetylcholine, and the patient's got depolarization block, which I'll show you what that looks like in a second. So of course, here's that electrical potential traveling down this nerve, releasing acetylcholine at the receptor level, and then within the receptor you can see an influx of sodium and so forth, which is going to assist in the membrane depolarization. And so this is what this translates to. So when you've got when you supply this test, and the patient has a poor response from stimulation, basically you've got too little acetylcholine, and the amount of acetylcholine is not enough to really increase the membrane potential dramatically, and so you never reach membrane potential, so you don't have the proper muscle contraction. Here you've got in the green, you've got too much acetylcholine, and so this muscle just stays depolarized longer, and it doesn't properly recover. Okay, and so that's kind of the take-home message with that. And so of the reversible acetylcholinesterase inhibitors, pyridostigmine and neostigmine, as well as physostigmine, have been really shown to be good drugs to actually treat myasthenia gravis. Adrefonium is a good drug to first diagnose myasthenia gravis, but also to determine whether or not you're too high or too low in some of these. And the reason is because adrefonium is very, very short acting. These three are longer acting. Other acetylcholinesterase inhibitors that are reversible include I can never say this one, dimecarium, and these are really kind of used specifically in glaucoma, as well as some other eye exams and so forth. And so that's where the bulk of these drugs are used. And so pyridostigmine, typically given orally, and then we had talked about the physical outcomes of having too little or too much drug, and of course adrefonium, which is the shorter acting version. Okay, and so this is just kind of a nice summary diagram of kind of patient management approaches to myasthenia gravis, and some of the more physical representations of the disease. And then here's just a treatment summary, which we'd already talked about. And so in terms of treatment, we can talk about drugs. Cortisol has also worked. Plasmapheresis to actually filter the blood and remove the offending antibodies that are kind of driving the disease, that could work. Some patients might have residual thymus that can kind of be contributing to this disease pathogenesis, and of course all this will be summarized in pathophys or pathology, and so a thymectomy could work for some of these patients. Okay, and so the main take-home points here in terms of myasthenia gravis are using intermediate duration acting acetylcholinesterase inhibitors to kind of manage the disease, and then challenging the system with a short-acting adrefonium, which is another acetylcholinesterase inhibitor, to kind of make sure that you're on the proper dose in terms of being too high or too little, because they all experience muscle problems and so forth, and so we want to make sure that they're properly managed. So that's the end of myasthenia gravis and the acetylcholinesterase inhibitor component to this lecture. Let's talk about some of these other more dramatic acetylcholinesterase inhibitors.